Welcome to Understanding Respiratory Failure, Session 1 of the Oxygen Masterclass. This is a live recording of a webinar presented by Dr. Joe Congleton, South East Coast SHA Clinical Co-Lead and Consultant Physician at Worthing Hospital.
Thanks, Rachel. So that's good. I don't need to introduce myself. So what we'd like to get out of this session are these. First of all, I'd like to go over the basic concepts around respiratory failure. Secondly, so that you have an understanding of interpretation of arterial blood gases. And thirdly, so that you understand the rationale for prescription of home oxygen. Now, respiratory physiology is a fiendishly complex subject, and there's lots that actually isn't worked out as yet, but there's some basic things that we can all know that will allow us to look after patients, and the finer details of some of the physiology aren't necessary for us to care for people. So first of all, starting very simply with the definition of respiratory failure, it's basically when the lungs are unable to maintain a normal oxygen level in the blood or a normal carbon dioxide level. So failure to keep those values within normal limits is a definition of respiratory failure. Gas concentrations in the blood are actually measured as partial pressures, so the pressure that a gas would exert, which is an unusual and odd concept to try and get your head around, but basically think of the numbers as concentration of gases. And they're measured in kilopascals in modern terms. You may see some old papers, or I think the American literature still uses millimeters of mercury as a pressure, and the conversion factor is about 7.5. So if you times or divide a millimeter of mercury figure by 7.5, you'll get the kilopascal equivalent. So what are the normal values? There's obviously a range, and they're not absolute, but as a basic number of values, these are up on your screen now. So PO2 ranges from just over about 10.5 kilopascals to 13. The values are a bit lower in normal elderly people, but that's the general range. And carbon dioxide level, you can see 4.6 to 6. So they're quite simple. And coming on to pH, it's a bit counterintuitive because pH is actually an inverse log value of a hydrogen ion concentration. So it's a measure of the acidity of the blood, the degree of acidosis of the blood, but a low level means a higher hydrogen ion concentration, i.e. more acidotic, and vice versa. So it's a bit counterintuitive. The other important thing to remember is that it's a log value. So that means that each increase by 1 point or each decrease by 1 point is actually multiplied by a factor of 10. So seemingly small changes in numbers around pH can actually represent a big change in the acidity of the blood. And I think what I see with our junior doctors is not enough importance being given to the pH and small changes in pH. It's probably, when you're looking at blood gases, the most important value. So what respiratory failure is not, is that it isn't dyspnea or a feeling of breathlessness. It's not hyperventilation, i.e. overbreathing. It's not hyperopnea, which is a normal physiological response after a great degree of exertion where there's big movements in tidal volume and high respiratory rate. And the other thing it isn't is fast breathing. It's not tachypnea. So the only way that you can diagnose it is by measuring something, either oxygen saturation or PO2, PCO2. This is a rather fuzzy picture of a hemoglobin molecule, which you can see is made of 4 different parts, the purple, yellow, the green, and the brownie colour. and each of those binds two oxygen molecules. The hemoglobin molecule, bless you, is a very special molecule because it changes shape as it acquires oxygen. And so when the first two oxygen molecules join in one of the segments, that makes it actually easier for the next two to join and the next two, and vice versa when unloading oxygen. And this stereotactic change explains why the oxygen dissociation curve is not a straight line, but it's a sigmoid curve that you're all familiar with. Now, there's a few very important points about this curve to note. I could grab my mouse back, I'll be able to show you. The first thing is that the oxygen saturation of around 90%, if you drop that down, is about 7.5 kilopascals. So a PO2 of 7.5 for generally will mean that the blood is 90% saturated with oxygen, i.e. generally enough oxygen saturation to deliver to the tissues adequately. The second thing is that as you increase the PO2 up here to the right, you don't get much increase in the oxygen saturation. And you can see this graph is by Anesthesia UK, and it's a shame that anaesthetists don't seem to understand this. As far as I can see, they're always trying to push up the PO2 massively, and as you can see, you've got diminishing returns. And as you'll hear about from Julia later, this actually might cause adverse problems for our patients. The third thing is that once you come down off around this 90%, and the PO2 is coming down along to the left, the oxygen saturation, so the oxygen carrying content of the hemoglobin, is actually falling off rapidly. And that's why we're happy with when people are saturated here about 90% with a PO2 of 7.5, but as things drop below 7.5, below 6, we become less happy about the patient. And that's why when we're talking about target saturations, and we'll come on to that later, we're aiming to keep people on the shoulder of this curve. There's minutiae here of how this curve shifts with temperature or increased acidity, but you don't need to take this into account when we're looking after patients. But understanding the importance of the curve is helpful. So, as we've been talking about, the partial pressure, the kPa, the PO2 affects the amount of hemoglobin that's saturated, but the important figure is the degree of hemoglobin saturation, because that's the main determinant of how much oxygen is delivered to the tissues. So I'd like you all now to have a think in your, wherever you are, your offices or your home or in your garden, about the basic mechanisms that lead to hypoxemia. We're not talking about disease processes in this instance, but actual mechanisms. Don't worry, here they are. So first of all, hypoventilation, underventilation of the lungs. And a sort of classic is breath holding. If any of you've got children that breath hold and go blue, you'll see that in action. So that's one basic mechanism. Second, and probably most important over all causes of hypoxemia clinically, is a disturbance or a mismatch between the ventilation and the perfusion of the lungs. So if you imagine a asthmatic someone whose airways are blocked with tenacious sputum, then that part of the lung isn't being ventilated. However, that part of the lung will still be perfused with blood, which won't be oxygenated, leading to the overall oxygenation capable of the lungs being low. And that's the ventilation being off, but the other way is the perfusion being down. If you think of destruction of the pulmonary vasculature, and there you might get areas of lungs that are ventilated, but the capillaries are destroyed and not able to take away oxygenated blood. Number 3, And you still get patients who've got through their life and end up coming to respiratory clinics with this problem occasionally, is a shunt, where blood is being shunted and bypassing the lungs. So the classic is a left to right shunt. And this is something to watch out for, although rare. Apart from cardiac shunts, there are shunts in other parts of the system, but cardiac shunts are one cause. And the next one down isn't important clinically, but just thinking about basic mechanisms. If you're up high at altitude, then your FiO2 will be low, and this will cause hypoxemia. And on top of Everest, the PO2 of climbers there is about 3.5, which is shockingly low. Exercise is an interesting one, because with normal lungs, however high the cardiac output is, for most people, the lungs can oxygenate that cardiac output. So exercise does not cause hypoxemia in normal people. So if your patient desaturates on exercise, then there's something pathologically wrong. The only exception to this are some extreme athletes who can actually put out such a high cardiac output that the lungs cannot keep up with that. And the two groups of those, not all of them, but some Olympic rowers and some cross-country skiers that have such a high cardiac output that they will get a bit of oxygen desaturation, but as a general rule that doesn't happen. So these Brad Wiggins here going up the Col de Galibia will not get hypoxemic. So that's the basic mechanisms. Now to disease processes. And I've made a list, it's not exhaustive, but of general disease processes that cause respiratory failure. So pneumonia, get the lungs congested and the solid, and you get a mismatch, the VQ mismatch there. Acute severe asthma. Asthmatics presenting acutely, I think, are all often surprisingly hypoxemic. Interstitial lung disease, the capillary, alveolar capillary interface is destroyed, and we're getting a VQ disturbance there. ARDS in some ways behaves like pneumonia, as does pulmonary edema. And COPD also gets, if you think about emphysema getting destroyed, alveoli and capillary. On the right-hand side, you might see that these are slightly different types of conditions as a whole. So overdose, we're getting reduced depressed ventilation, a CNS catastrophe where there's brainstem affected and reduced ventilation. Weak muscles, again, neuromuscular conditions such as Guillain-Barré or motor neuron disease, the lungs cannot function adequately as a pump. Chest wall deformity, and COPD, you'll notice, comes into both groups. So the group on the right-hand side primarily are pump failure problems or problems of hypoventilation. And the group on the left are problems of VQ disturbance. And you'll see that the group on the left primarily cause a hypoxic respiratory failure, whereas the group on the right, their pump failure, ventilatory failure, cause a hypercapnic respiratory failure in addition. And you can see that COPD is interesting as it falls into both groups. So just to recap, hypoxic respiratory failure is caused when there's a problem in gas exchanging units, and there's the list there. And hypercapnic failure is pump failure, failure of ventilation. And COPD comes into both, but it's very important that it causes a hypercapnic respiratory failure. This affects how we manage patients. One way of thinking this, because it can be, I think, hard to understand why COPD causes hypercapnia, is to think about this balance between load on the lungs and the capacity of the lungs to deal with it. So the increased load of the lungs is due to the increased airflow obstruction, maybe retained secretions, and there's loss of elasticity causing increased airflow obstruction, coupled with the reduced capacity such that as the lungs hyperinflate, then the muscles are working at a mechanical disadvantage, so the capacity of the lungs to overcome this worsens. Coupled with that, this can cause tiring, and the capacity decreases further, hyperinflation increases, and load increases further. And this is sort of conceptually a way to think about pump failure in COPD. So we've done some mechanisms now interpreting arterial blood gases. So you do always need to know what FiO2, what oxygen the person was breathing when you are interpreting the blood gases. So you should always look out and see what's written down. But what isn't necessary in the acute state is to take someone off oxygen that they need just to do the blood gas. We can cope acutely by just writing down what oxygen the patient needs. It's rather distressing to see someone with a PO2 very low where their oxygen's been removed. So we talked about the sigmoid curve for oxygen saturation, whereas there's a carbon dioxide is dissolved in the blood, and you can see down on the bottom right the Heisenberg equation. I haven't said that properly, but I'll get through that. And basically, when you get increased production on one side, that moves the equation over to the right. So if extra carbon dioxide is produced, that shifts things over, and you get an increased acidosis. And if there's an increased acid produced, for example, by the kidneys, that shifts things the other way. So that at any point you get this straight line relationship between carbon dioxide and hydrogen ions. So changes in the acidity of the blood or changes in the pH, primarily caused by the carbon dioxide level either rising or falling, are called respiratory changes. And changes in the degree of acidity of the blood or the pH caused by alteration of bicarbonate concentration are metabolic changes. And in the blood isn't allowed to get to acid, and there's a buffering system, and this system is the bicarbonate and carbon dioxide the most important, and you get chronic changes. Some of you might have seen these charts in the textbooks as an aid to interpreting arterial blood gases. I have to say I've never used them or found them helpful, and I find that just confusing. But if you find that a good way to do it, that's fine. I think looking at simple patterns is much more useful. So we've got 6 patterns coming up. First of all, very simply, hypoxic respiratory failure. So this is the asthmatic who isn't yet tired and needing to go to ITU, or patient coming in with pneumonia, or someone maybe in your clinic with interstitial lung disease. So if you do their arterial blood gas and they're in respiratory failure, the PO2 will be low. The PCO2 may be normal or maybe a little bit low because they're relatively increasing their tidal volume and respiratory rate in order to try and push up the PO2, and the pH will be normal. So that's an important pattern to recognise. The next one here, I think your eyes should be taken to the fact that the pH is low, so that's an acidosis. We look at that and the CO2 is high, so then we know that's a change in acid caused by CO2, so that's a respiratory acidosis, respiratory failure. And the PO2 will be low in addition. So that's a simple acute acidotic respiratory failure. Some people use type 1 and type 2 for these 2 types. So I personally don't find that too helpful, but there's nothing wrong with that. I prefer to say acute hypercapnic respiratory failure or acute respiratory acidosis. I mentioned the buffering system before, which the kidneys really maintain, and when we get a chronic hypercapnic respiratory failure, this buffer system comes into play. So the pH is normalized, but the carbon dioxide remains high. The second set is the set on the left in green is commonly seen on the acute take. So this is seen when someone has got chronic hypercapnic respiratory failure but come in with an exacerbation, so they have a decompensated hypercapnic respiratory failure or acute on chronic respiratory failure. So there the pH is low and the CO2 is high, but the levels are not matches for the acute hypercapnic respiratory failure. There's been some compensation. Now, when you get used to looking at the blood gases, you'll sort of note the figures don't quite match up. But the way to be sure about this is if you look at the bicarbonate level, the bicarbonate will be high, of the order of around 30 or more, and it's that high bicarbonate level, the bicarbonate is being retained by the kidneys, that's the clue to this is not just an acute respiratory failure, but there's a chronicity about it as well. An important thing to know is that the bicarbonate is just calculated from the blood gas machine. So the only things that the blood gas machine measures are the PO2, the PCO2 and the pH, and the rest is calculated. That's why they're the three measures that I've put on the screen there. So those four that I've talked about already are the most important patterns for respiratory patients that we see. But it's important to recognise the others so you don't get caught out. In the middle column in grey is an example of metabolic acidosis. Things such as diabetic ketoacidosis or salicylate poisoning can cause this. So the pH is low, you know that's an acidosis, but there the CO2 is low as well. So the acidosis is caused by metabolic problems rather than respiratory problems. And on the right-hand column in the mauvey colour is an example of respiratory alkalosis, and a classic cause of this is hyperventilation, panic attack, where the PO2 is high, the CO2 is low, and the pH is high. So it's an alkalosis because the pH is high, but the CO2 is low, so you know it's caused by the lungs. Okay, so I think recognising those patterns is important. So when do we use oxygen? So these are the broad terms for all patients. We use it in an emergency situation in critically ill patients, and the aim is to improve oxygen delivery to vital tissues. So we're optimising oxygen delivery to the tissues. We use it as part of management of acute respiratory failure to aid reversal. And the second half of this slide is what we're going to be dealing with more today. So we use it to prevent end organ damage caused by chronic hypoxemia, and that's the classic use of long-term oxygen therapy. Secondly, there is a use to facilitate increased activity, and increased activity with reduced symptoms such as breathlessness or reduced recovery time for patients who desaturate on exercise. But as I've put there, it's not used to palliate the symptoms of breathlessness when there is no hypoxemia or respiratory failure. So how do we administer oxygen? Just a quick recap of that. The main forms the top three. There's variable performance masks, which are normally for delivering high flows and high concentration of oxygen. Number two is very important for COPD patients, particularly in acute respiratory failure, when we use a fixed performance mask and using the Venturi principle. And this is a very important concept, is that when we use these types of masks, we know exactly what oxygen concentration we're delivering to the patient, i.e. that concentration is independent of the pattern of breathing. At home in stable patients we use nasal cannulae, but these are variable performance. The amount of oxygen delivered to the patient depends on their respiratory rate and their tidal volume, i.e. their minute ventilation. And these two at the bottom, the transtracheal oxygen and oxygen tent, are really small print just to fill up the slide. So here's a picture. So the top is our nasal cannulae, and it's important to remember that what's coming out of the tips to the patient is 100% oxygen, and there's a kind of just a guesstimate amount of air that mixes with that, so at the very best you can guesstimate how much oxygen you're giving a patient. But if your respiratory rate is low and your tidal volume is low, you actually might be giving your patient quite a high percentage of oxygen. And so because of the risk of hypercapnia in the acute state, we nearly always use this Venturi controlled oxygen therapy. So long-term oxygen therapy, which is the main type we use in our COPD patients, the evidence base for this. There were two trials, the MRC trial in the UK and the NOT trial in the States. The MRC at the bottom there was a placebo trial of oxygen 15 hours a day with no oxygen, and the NOT trial, both groups had oxygen either 12 or 24 hours a day. About 200 people in the MRC trial and 80 in the NOT. And this graph is a summary of both of the trials put together. So the blue line at the bottom is a control group that had no oxygen, and the axis on the left is the survival and time along the bottom. And as you can see, there was actually no benefit of having oxygen 12 hours a day as opposed to no oxygen at all in this group of COPD patients with hypoxemia. In the UK study with 15 hours of oxygen, you did start to see a survival advantage, which is the green line, but the biggest survival advantage was for patients taking oxygen 24 hours a day. So people often think, and patients often say, well, I've had my 15 hours a day, I'm done, but actually I think it's very important that we explain to patients that the longer of duration of oxygen in the day, the better the effect. And survival was the only outcome that really there was a difference in the groups. So, as you all know, long-term oxygen therapy is indicated for patients with COPD for PO2 less than 7.3 kilopascals when they're in the stable state. So the decision isn't to be made when they're just coming out of hospital after an exacerbation. It can take a couple of months for things to normalise. The survival advantage really comes into play only after about 2 years for men, so there's no big rush to get the oxygen in. It's much more important that the patient understands the commitment, understands the reason for it, and is prepared to have long-term oxygen therapy. The other group are between 7.3 and 8 kilopascals who have evidence of end organ damage, i.e. polycythemia, nocturnal hypoxemia, peripheral edema, or pulmonary hypertension. Although there's no good evidence for this group, they're sort of in a grey area, and it's thought that they should benefit. And here's a little summary of what I've just said. The other type of oxygen used at home is ambulatory oxygen, which I've put three main uses there. Firstly, it's an adjunct to using the concentrator in LTOT, and basically that's a way of allowing someone to increase the amount of time they spend in 24 hours on oxygen. And as you can see from the graphs I showed you, then that's likely to give a better advantage. Secondly, to facilitate daily activities in patients with exercise desaturation. Having said that, the evidence is slim. A lot of the trials are a small number of patients, and what I find when we test patients is that patients often don't feel any better exercising on oxygen or walk any further. So it's very important that you assess this objectively. And the third group, which there is some evidence for, is as an adjunct to exercise training in patients who do desaturate. So they'll get a better training effect if they train on oxygen. That's just a summary of what I've said, and there's some references there, but we will be able to make the slides available. you probably all know that there's very little evidence for short bursts. Oxygen therapy being of any benefit, very inconsistent results, and it's really something that should be discouraged. And mostly, I think most people feel that it's a very expensive placebo. Palliative care patients are a group that are often considered for oxygen because breathlessness is quite a prominent symptom, but there is actually pretty good evidence that it is not of benefit for patients who are not hypoxemic, and other strategies such as opiates or a fan should be used instead. So I think a palliative care group, people often want to do something, but oxygen may not be the best thing for your patients. So, finishing up, in summary, I've described the main mechanisms of the two types of respiratory failure, pump failure and VQ mismatch. I've shown a simple scheme for pattern recognition for interpreting arterial blood gases, and I've just given a very brief overview of the evidence for the use of home oxygen. And I think we might have some questions. So we've got someone, Susan Lipscomb, asking, are you planning to mention use in cluster headache? I wasn't actually. The cluster headache is one of the indications. Actually, if you go back and look at the papers, the evidence is really rather slim, but it does seem to be a group that are prescribed it. I think what I would say is that you need to be sure that your patient is really benefiting from it, because from my experience, sometimes people have oxygen in for cluster headaches and it hasn't been used for years and years. So it is one of the things that seems to have got on the books, but I think without brilliant evidence.
We hope you enjoyed Session 1 of the Oxygen Masterclass. Session 2 is also available and will be covering the risks and dangers of oxygen.